look at the role of chest X-ray in cardiac disease. Strange, isn't it? Dr. Fox didn't speak about chest X-ray in his talk, did he? Do you think it's important? Yeah? You think it's important? How many of you think chest X-ray is important for a cardiac patient? So just half, maybe half of you. You have to think hard, isn't it, to raise your hand, it's important or not. Okay, so that's interesting. So we'll try to understand the role of chest X-ray in today's modern cardiac imaging. We look at the different common abnormalities we can see on a chest X-ray and also understand what the limitations are. So in terms of what we need to know for diagnosing a cardiac condition, morphology is very important from imaging, which is what we do as radiologists all the time, is looking at the anatomy, the morphological aspects of disease. So from heart perspective, we need to know the coronary arteries, the anatomy, need to know the presence or absence of plaques in the coronary arteries, how much stenosis they are causing in a patient with chest pain, for example. In a patient with heart failure, we need to know about the size of the different cardiac chambers, the myocardium itself. Is it thick? Is it thin? Is there any infiltration or anything that may explain the patient's heart failure? You need to look at the valves, the veins, the aortic root, the thoracic aorta itself, pericardium. So there are lots of structures in and around the heart that we need to know about from cardiac imaging. But heart is also unique, I think, from other organs in the respect that function is very important in diagnosing a heart disease as well. So from function point of view, we need to assess the function of the ventricles. We need to know about the perfusion of the heart, about the viability of the myocardium, the heart muscle, and how the flow is through the valves and the aorta. So it's a combination of morphological as well as functional information we acquire from imaging. And we have seen that from Dr. Fox's talk earlier that we have a range of modalities that we can use to assess these different aspects of the heart. But the important question is, what role does chest X-ray plays in diagnosing heart disease? So anyone, what is the most important thing, 1, 2, 3, 4, that we still use a chest X-ray in a cardiology department or from cardiologists?
Heart size and evidence of pulmonary.
Okay, so that's a patient you want to assess what? If the patient has heart failure or not, yeah, by way of looking at pleural effusions on the chest X-ray by means of looking at pulmonary edema. So we're trying to say, does the patient have heart failure or not? Okay, so that important use of chest X-ray, that probably I would think is the most important and perhaps the most widely used indication for a chest X-ray in clinical practice in a hospital. Okay, other uses you may think of? When, in which other situation would you use a chest X-ray?
Putting a device.
After putting a device, yes, after putting a pacemaker or an ICD, you want to check the position of the leads, you want to check for any complications, yeah, that's an important indication for which chest X-ray is mandatory, yeah.
Patients with chest pain, no idea with chest X-ray.
So chest pain, which chest pain?
Any chest pain, generally you
Yeah.
probably want to do a chest X-ray as a baseline.
Yeah. So you would, like as a baseline, you could do a chest X-ray, and chest X-ray can be used to exclude certain things. It may not give you a diagnosis of chest pain, but it may be helpful. Okay, so anything else? And acute chest pain, it may have different uses. You may want to look for pneumothorax, you may want to look for any widening of mediastinum for type A dissection, for example. In a stable chest pain, the importance is less, but again, it's the same things. You want to exclude pulmonary pleural causes. pleuropulmonary causes of chest pain. Yeah, you won't be able to diagnose coronary disease with chest X-ray, but you will exclude other possible causes. So important thing is that the chest X-ray, I think, acts as a window to the whole cardiothoracic system. So it's very simple, very crude technique, but it's a window, or gives an overall view of heart and lungs. So so heart failure, I think, is the commonest indication for doing a chest X-ray to exclude lung diseases which may be responsible for chest pain or for breathlessness. Pleural effusions, which can be part of heart failure, which can be part of pleuropulmonary disease. Then mediastinal widening, which by itself could reflect, besides thoracic disease, could reflect aortic aneurysms, for example, can reflect aortic dissection. Very important. Position of the device, which is important, and its complication. And bony abnormalities. Certain bony abnormalities can reflect on presence or absence of certain cardiac conditions. Okay, so those are the main indications. So the radiologist here would know what are we looking in terms of quality of a good chest X-ray. So symmetry of the chest of the patient's position. The X-ray should be taken in a good inspiratory effort. Minimum magnification of the heart size, and that's done by usually a posterior anterior PA view of the X-ray when X-ray is taken in the department. You can have a portable X-ray, obviously, which could be an anteroposterior view. There should be adequate penetration of the chest in the X-ray and optimal contrast between the different structures. So those are the qualities of good quality X-ray. So what are the structures or areas we are looking at in a cardiac patient or patient with suspected cardiac diseases? What are different bits on the chest X-ray we're looking at? Looking for heart size with cardiothoracic ratio. What else? Mediastinum contour.
And then the costographic angle.
Okay. Anybody, anything else? That's it. So cardiac size, mediastinum, and cost-differential angles. What else? Pulmonary edema. You mean the lung parenchyma, or you mean the pulmonary vessels? So pulmonary vessels are important. From a cardiac perspective, pulmonary vessels are important. But obviously you're looking at the lung parenchyma as well, looking at the hyla, you're looking at the bones again. So all these provide different information. The most important structures you're looking for in a cardiac patient is pulmonary vasculature. Okay, that's the most important information because the size of the pulmonary vessels, they reflect the pressure in the heart. Okay, you may have a normal heart size, but if you have distended pulmonary vessels, that may represent increased cardiac pressures. Okay, so that's the one most important size. And then you're obviously looking at lung fields and hyla, and then you're looking at the heart size. Okay? And with the heart size, you're looking at the different enlargement of cardiac chambers and thoracic aorta. And then you look at the supradiaphragmatic region and the bony skeleton. So those are the different things, and I put them in the order of importance in a cardiac patient. So if you look at a chest radiograph and see what are the different structures in relation to the anatomy we see. So on the right side, starting from cranially, so what is this structure normally formed by here, this area? So you can see here, that's the SVC, okay? So in a normal patient with normal pressures in the right heart, it's barely visible, SVC. But if you have patient with right heart failure, this can become distended and may become prominent. What's the other possibility? What other structure is here? Ascending aorta. So you can just see here ascending aorta. So if there is aneurysm dilatation of the ascending aorta, you can have a prominent bulge in that region. And then you come to the hyla. The two hyla are formed by the pulmonary arteries and the veins. So normally, but obviously you can have enlargement of these pulmonary vessels causing enlargement of the hyla, but you can also have enlargement of the lymph nodes that can cause enlarged hyla. Then What about the right border, right cardiac border here? What structure forms this? Right atrium forms the right cardiac border. Inferior, so this is right atrium here, and this is showing this is the right atrial appendage. Okay. What about the inferior surface of the heart? The right ventricle. Good. Apex of the heart? Left ventricle. Okay, so this you can see here. So anterior surface of the heart and inferior surface is formed by the right ventricle. The apex is formed by the left ventricle, and the left cardiac border is by the left ventricle. And then above this here, what you have? So what is the structure? What I'm pointing to? So that's the pulmonary trunk. Yeah. The main pulmonary artery leading posteriorly into the left branch, and this passes over the left main bronchus, which you can just see here. Between the pulmonary trunk and the left ventricle, there is generally a bit of convexity here, and that is occupied by the left atrial appendage, right? And then you have the aortic knuckle formed by the aortic arch, this structure here. Okay. So, and this is showing the same thing. This is an MRI image which shows the SVC, ascending aorta, bulge here, the right atrium, left ventricle with apex. This is the pulmonary artery. This is the left atrial appendage and the aortic knuckle. So this is just to show the pericardium that surrounds the heart. Yeah, we'll look at the anatomy of pericardium in more detail. Well, the two layers of pericardium, they extend quite a way up along the great vessels, along the ascending aorta and the main pulmonary artery. So almost as high up as the aortic arch, they can go up. So when patients develop pericardial effusions, we can see the effusion tracking all the way up. Okay, so coming back to the chest radiograph. So what about this X-ray? Whose X-ray is this? Neonatal, infant, newborn X-ray. Is this normal or abnormal? Is it normal X-ray? Those at the back, can you hear me? I think I'm probably slightly need to speak louder. Okay, so this is a normal X-ray of a neonate. Sorry? No. Okay, so this is normal because of it's in a supine position, first of all, so there is a lot of magnification here of the heart, but also neonates and infants have large thymus as well. So in a neonatal or infant age group, you can have a very wide looking heart and mediastinum, but it's normal. Now coming to a very common X-ray presenting in adult cardiology clinics, you can say, is this one here. So if you want to go through the findings here, okay, let's start with heart size. What do you think about the heart size here? Is it normal or it's large? It's large, okay? Everybody agrees with that. What about the pulmonary vessels? Yeah? There is upper lobe diversion or upper lobe vascular redistribution is there. Okay. We'll look at that again. Anything else? So increased heart size. Second is upper lobe vascular redistribution. And anything else? Third, lungs otherwise clear. Double right border. What does that mean? Here? Yeah, double right border. So this is the normal right border, and there's an extra border coming here. That represents the left atrial enlargement. Okay. Anything else there? So no pleural effusions, lungs otherwise clear, and no obvious bony abnormality. Okay. So how do we measure the heart size? So we take the maximum diameter of the heart from the most right lateral border to the most left border, okay, excluding the pericardial fat. Okay, we should not take that into account. So the solid margin on the left side and solid margin on the right side, and then dividing that by the most widest part of the internal thoracic diameter. So cardiothoracic ratio up to 0.5 in adults is normal, in children it's up to 0.6. Okay, that's how we measure cardiothoracic ratio. So it's a very crude measurement of the heart size. Is it a sensitive way to say if somebody's heart is failing, is dilated? Is it sensitive way? So when you say sensitive, do you understand what I mean? Sensitive, is it sensitive to pick up heart failure? It's not sensitive, okay? So you can have absolutely normal size, but patient with a poor ventricle. But if it's dilated, then it means something is wrong. So I can say it's specific, but not very sensitive. Okay, so looking at the pulmonary vessels, so what are these? So we're looking at upper lobe vascular redistribution or upper lobe diversion. What are they? Are they arteries or veins?
Veins.
They're veins, yes? They're veins. So why are the veins distended? What does it mean? So there's increased pressure in the left atrium. What's the normal pressure in the left atrium? Less than 10? Yeah, less than 12. Yeah, up to 12 is the normal pressure in the left atrium. How do you measure the left atrial pressure? Cardiologists, how do you measure left pressure? Pulmonary capillary wedge pressure. So if you have seen the Swan-Ganz catheter, so if you put it through the SVC into the right heart, then pulmonary artery, and take it all the way peripherally into the branches, you can measure the pressure in the left atrium. It represents a pulmonary venous pressure, and in a patient with normal lungs, that would represent the pulmonary venous pressure. So normally less than 13. So when the pressure increases to more than 15, you start to get back pressure from the left atrium into the pulmonary veins, because as you know, pulmonary veins are draining blood from the lungs into the back of left atrium. So direct effect of pressure from the left heart goes into the pulmonary veins. So that's an important sign. And this sign only we see if the X-ray is done in an erect position. Okay, in a supine film, this sign is not applicable. Okay, so what are the causes of increased pressure in the left heart? So any cause of left ventricular dysfunction will cause this. Okay, and what is the commonest cause of left ventricular dysfunction? Ischemic cardiomyopathy. Okay, so patients with severe three-vessel disease causing left ventricular dysfunction would cause increased pressure in the left ventricle, which will cause increased pressure in the left atrium, and which will go back into the pulmonary veins. Then dilated cardiomyopathy, other cardiomyopathies like hypertrophic or restrictive cardiomyopathies. Then any of the aortic or mitral valve disease will cause the same thing, whether they are regurgitant or they're stenotic. Okay? They will cause increased pressure in the left cardiac chambers. Then other causes of left ventricular failure like myocarditis, alcoholism, some certain chemotherapy drugs can cause LV dysfunction, radiotherapy can cause LV dysfunction. Anything that impairs the contraction of whether systolic or diastolic contraction of the left ventricle will cause increased pressure in the left heart, and hence raised upper lobe vascular distribution. So what the word that is used for engorgement of the pulmonary veins is the pulmonary venous hypertension. Okay, we'll come to that in a moment. So now let's go take a step further. So this is another X-ray here. So now pressures have increased slightly. They're more than 20, but less than 25 millimeter mercury. So what are we seeing on this X-ray? Sorry? Pruning. Somebody said pruning? Say aloud. Don't worry if you're wrong, doesn't matter. You have all come for learning. Sorry? So pruning, okay. No, I wouldn't say pruning. So pruning means there is absence of vascularity in the peripheral third of the lung parenchyma. Here you can see the vessels going all the way peripherally. If you observe carefully the pulmonary vessels here, their margins are irregular. Yeah, they're blurred, and that happens when pressures go up slightly more, and there is the plasma from the vessels, pulmonary veins, go around in the interstitial or perivascular space. Okay, perivascular cuffing, it's also called peribronchovascular cuffing. So this stage is an advanced stage than the upper lobe diversion, but it's just before pulmonary edema. Okay, an intermediate stage. So if you then increase the pressure, this is just showing you in detail the cuffing of the pulmonary vessels, veins, and the arteries. So this is another example of similar acute presentation of patient who coming in acute heart failure and has got increased vascularity with blurred margins of the pulmonary vessels, so perivascular cuffing. Now, what is the other sign that you are seeing here? So heart is in large size, and there is prominence of the, what is that structure? Pulmonary artery, yeah, main pulmonary artery. Okay, this can be large in young females normally also, but important thing I think is this is quite large, I must say, and the heart size is increased. So this patient, same patient's X-ray, what do you see there? So you can see here there is there's a catheter going in, and it goes like this and goes into the right pulmonary artery. This is a Swan-Ganz catheter. Anyone, what operation has the patient had? Yeah, so you can see there's a valve here, a metallic valve. So this is in mitral position. So patient has had mitral valve replacement. So patient had severe acute mitral regurgitation, because of which patient had pulmonary congestion and acute breathlessness. Okay, so this is after cardiac surgery, and those congestive appearances have now reduced post-surgery. Okay. Now, what about this? So there's a quite extensive airspace shadowing. So the word we use now in radiology is airspace shadowing. So cardiologists who are not familiar with this word wonder what this means, but we are meaning generalized opacification. It could be focal as well, but generalized opacification of the lung parenchyma, and it occurs. Two common causes would be pulmonary edema if it is bilateral, if it is symmetrical, or infection. You know, the word consolidation we don't use anymore. We use the word airspace shadowing. So if it's bilateral like this, generalized perihilar particularly, then we say it could be pulmonary edema in the right context, obviously. So you can see this patient has had surgery, a cardiac surgery. There are sternotomy wires in situ. There's a valve here. Yeah, patient is intubated. There is a central venous line in. There is there's a catheter going into the main pulmonary artery, and the chest drains there. Okay. So pulmonary edema can happen after cardiac surgery. But what else can happen after any surgical procedure? ARDS. And how would you differentiate between the two? Pressure where? Pulmonary wedge pressure. So in pulmonary edema, the pressure would be elevated, yeah, because that's the mechanism of pulmonary edema. While in ARDS situation, the wedge pressure will be normal. So that's how one differentiates. And the second thing you can do to differentiate, to ascertain this is pulmonary edema, what else can you do? Treat. So you can give diuresis and see a response. So pulmonary edema responds very quickly. Yeah, within a few hours, within the next day, you will see a resolution of pulmonary edema on the chest X-ray. And this is a patient, this is an old film I have with, this device is an ICD. So you can see a thick sheath here on the ventricular side of ventricular lead, and it's an ICD. But again, this X-ray, this patient also has chronic pulmonary vascular congestion. But there's some other things some other finding here which I just want to point out. And if you look carefully, you can see some horizontal lines in the bases. So they are called the curly B lines. Yeah, you can see septal. This is interlobular septal thickening that we see on the chest X-ray. So these represent chronic raised interstitial pressure. Okay, it does not happen in acute situations, but only in chronic situations. So, as I said, increased pressure in the pulmonary veins secondary to raised pressure in the left heart is called pulmonary venous hypertension. And if that pressure continues, that would cause increased pressure in the pulmonary arteries, simply back transmission of the pressure. And that eventually would cause right heart failure. And that's the commonest cause of pulmonary hypertension, arterial hypertension, and right heart failure is left heart failure. That's how it comes about, because the commonest cause of heart failure is ischemic heart disease. Hence, commonest cause for right heart failure and pulmonary hypertension is ischemic heart disease as well. Okay, what about this? Dilated central pulmonary artery. So this is the pulmonary artery. Okay, this here is very large marked dilatation of the main pulmonary artery. The knuckle, aortic knuckle, is very small here, and as you can see, the central pulmonary arteries are quite large. So what condition this could represent? Pulmonary arterial hypertension. What type? You're right. What type though?
I mean, like chronic.
Do you know types of hypertension, pulmonary arterial hypertensions?
Essential, secondary.
Essential or idiopathic or secondary. Yeah. So this is idiopathic pulmonary arterial hypertension. Idiopathic, because pulmonary arterial hypertension is a broad term, isn't it? Anything, whichever condition you have raised pressure in the pulmonary artery, you could call pulmonary arterial hypertension. But probably idiopathic pulmonary arterial hypertension is what would cause massive enlargement of the central pulmonary arteries. And what's the second cause? What's the second possibility? What else can cause this appearance? No, massive P will not cause this. PDA, you are close.
ASD.
ASD. In what situation? Eisenmenger's. Undiagnosed, Eisenmenger's. Yes. Chronic. So left-right shunt from ASD or VSD or PDA that has gone untreated, and patient develop reversal of the shunt, not right to left shunt. That's called Eisenmenger's. So Dr. Mike Rubins is going to speak about congenital heart diseases on Saturday, and he's going to touch on this. But there are only two conditions that would cause massive enlargement of the central pulmonary arteries, like this. Okay, so Eisenmenger's and idiopathic pulmonary arterial hypertension. Okay, so let us look at some specific cardiac chamber enlargement. So, patient has cardiomegaly, no doubt. Yeah, heart is enlarged in size. You don't have to measure, if it's obviously enlarged, you don't have to measure the cardiothoracic ratio. So which chamber is enlarged here, you think?
Both atrium. You need the atrium.
Which atrium?
Both.
Both atrium. How do you say that? Prominent? Okay, tell me ventricle. Focus on ventricle here. Which ventricle is enlarged?
Right.
Why do you say right?
The apex is extended.
Is that a feature of right ventricle enlargement?
No, I said the apex isn't.
Okay. So if the apex moves to the left inferiorly, that's sign of left ventricular enlargement, as the apex is formed by the left ventricle. Okay. So this patient predominantly has left ventricular enlargement from whatever cause. Okay. So this patient again probably has left ventricular enlargement, and as you have told me that there is left atrial enlargement here as well with a double cardiac border, and also other sign, as you know, is splaying of the carina because of left atrial enlargement. Okay, what about this one? Left atrium enlargement? Okay, so there are two bulges here. One bulge is here. What is this bulge? This is right atrium enlargement, okay? And what about this bulge? Left atrial appendage, okay. So what is this a cause? So enlargement left atrial appendage is caused by what? Which condition causes left atrial appendage enlargement? Mitral stenosis. From which cause? Rheumatic. Okay, so it's specific to rheumatic valve disease of the mitral valve. We see enlargement of the left atrial appendage. Okay, otherwise mostly because as rheumatic valve disease are less common in the Western world, we don't see left atrial appendage enlargement like this. So this patient had mitral valve stenosis from rheumatic disease, had enlargement of the left atrial appendage, and subsequent pulmonary venous, pulmonary arterial hypertension, and also right atrial dilatation. Okay, what about this now? So if you see here, see this is odd here, isn't it? So what is this border formed by normally? Left ventricle. But when you see prominent convexity here, that is not enlargement of the left ventricle. That's enlargement of the right ventricle. So when right ventricle dilates, it rotates the heart backwards, behind. So it anti-clockwise it rotates the heart like this. So right ventricle, which is anterior, as it dilates, it will rotate the heart clockwise direction. And then it will form a bulge in the left cardiac border. Okay, so this is right ventricular enlargement. Okay, this patient, young female. So there is again here prominent left heart border, right ventricular enlargement. So first of all, overall heart size is much enlarged, much dilated. Then there is the prominent convexity of the left heart border, indicating right ventricular dilatation. And this one, right atrium dilatation. So if you see both right atrial and right ventricular dilatation, which conditions would come to your mind? Pulmonary hypertension could be. Tetralogy would not cause right atrial enlargement. But think of tricuspid valve regurgitation from some cause, or right heart failure by itself, primary RV cardiomyopathy. So this patient had, you can see this is an MRI scan. So massive dilatation of right atrium and right ventricle, and this is the septal leaflet of tricuspid valve. You see this is free flow of blood between the right ventricle and right atrium. This is called Epstein's anomaly. Epstein's anomaly of the tricuspid valve. So one of the causes of marked cardiomegaly. Okay. We'll see examples later on of these conditions. Okay, what about this? Dextrocardia? Any other guesses? Right atrial aneurysm. So you're extending your right cardiac border further rightwards, making it aneurysmal. Okay. Anything else? Any other guess? Pericardial cyst. Very good. Okay. So what would you do next? CT. You could do an echo. What about echo? Nobody will do echo? Can do an echo to see if you find something? Echo is not invasive. It's not invasive, isn't it? Okay, so lateral chest X-ray, does it help? I don't think they help, because I can't interpret them. I don't. We really do lateral chest X-ray. Okay, so what is this? It's a pericardial cyst. Yeah, it's large pericardial cyst, which was on the X-ray. If you go back to the X-ray, it looks almost like, you could say testocardia also, I think. It's large pericardial cyst. Other differential of this would be a large thymic cyst, because it's going to the mediastinum. You can see here, all the way up. Okay. So another large cardiac fluid. What else would you think of if you have a large cardiac fluid? In patient presenting with acute breathlessness. Sorry? Tamponade, pericardial effusion. Yes, pericardial collection. So always think of pericardial collection, effusion in an acute situation with a very large cardiac fluid. Okay? And also if patient has pleural effusions as well at the same time. So this patient has large pericardial collection. You can see fluid in the pericardial space all around. And the cause of this was lying just behind the heart. And this large tumor in the subcarinal region posterior to the left atrium. This large tumor is causing the pericardial collection. Okay. This X-ray here, cardiomegaly, boot-shaped heart. You are after boot-shaped heart and fellows, aren't you? Okay. Yeah, you could say it looks a bit like boot-shaped heart. And I can't explain why there's a bulge here of the right ventricle in this case. Anyone else? Anything else? Sorry? Somebody said something. Actually, it's subtle. I think I should tell you what it is. If you look at the rib margins, inferior rib margins here, yeah, this is a patient with coarctation. There's some undulation of the inferior rib margins. It's a patient with coarctation of aorta. So that's where the typical site of coarctation is, distal to the left subclavian artery origin. And coarctation is associated with, quite commonly, with bicuspid aortic valve, and also with patients with Turner syndrome, and aortic regurgitation is secondary to bicuspid valve generally, and also patients can have PDA at the same time, coarctation. Okay, so last X-ray. What about this? What are the findings here? Some cardiomegaly, okay. Okay, define the features first and then come to diagnosis. Okay. So right heart border is, can you see it? Can you see the right heart border? No, it's displaced to the left, isn't it? So it's behind the sternum. And there is some haziness here in the right pericardic region. What else?
Tubular shape.
Tubular shape of the heart. Okay. Why is that due to? Look at the ribs.
We usually see in patients with chronic pulmonary disease.
Yeah. Yeah, COPD, etc., barrel-shaped chest. Okay. So if you look at the anterior ribs here, they're very vertical. Okay. Yeah. So this is pectus deformity. So pectus deformity. So pectus deformity, the features on chest X-ray are vertically oriented ribs, heart displaced to the left side, indistinct right cardiac border. Okay. This is pectus. And to prove this, you do a lateral chest X-ray, or you see the patient, you will see the pectus deformity. Right? So there's so I just showed you a couple of bony problems that can be associated with cardiac diseases. So what we have gone through is some of the features of heart failure on the chest X-ray, which is by far the commonest use of chest X-ray in clinical practice. I've shown you some examples of different cardiac chamber enlargement. Although again, patients with heart failure will have an echo in the first instance, and the cardiac tumor size, etc., will be diagnosed through echo, but chest X-ray also gives some important findings. And then we've looked at a couple of examples of skeleton problems that can be associated with cardiac disease.